Perfect. Okay. Right, we'll get going then. Okay, so welcome everyone to the next STLE UK students webinar. So today we're lucky enough to be joined by two speakers. So I'll start off with giving the first speaker, which is Dr. Rob Beadling, a quick introduction, and then yeah, we'll go dive straight into his talk. So Dr. Rob Beadling is an assistant professor in the School of Engineering at the University of Birmingham. His research concerns tribology, the preclinical assessment of medical devices, and in situ assessment of material degradation. Mechanical joint simulation is the gateway for technology for the safe introduction of medical devices, but current standards provide limited actionable data on real-world performance. He has over 20 publications and has received funding from EPSRC, EU, MSCA, and industry. And so he'll be presenting a talk titled Linking Total Joint Replacement Preclinical Testing to Observed Clinical Failure Modes. So over to you, Rob. Thank you for joining us.
Brilliant, thanks, and thanks for that introduction, Sienna, and the invite to speak today. So I mean that's my background. I'm just gonna kind of jump straight into basically the talk and a bit of introduction and background as to what I'm going to be speaking about. So joint replacements, total hip replacements, are mechanically engineered devices where we introduce these kind of big lumps of metal basically into the body, where there's been a failure in the human joint. So usually this is a degenerative disease that's caused breakdown of the articular cartilage, something like rheumatoid arthritis. And the problem with cartilage is it's avascular and aneural. So by the time that there's an issue with the joint, avascular means it's not connected to the blood supply. It has trouble kind of repairing itself as a result of damage. And aneural means it's not connected to your nervous system. You can't feel cartilage. So by the time there's an issue, the cartilage is already worn down. The patient starts experiencing pain. That's typically where you're already kind of on a bone-on-bone contact. So at that point, your options are usually fairly limited, and you have to go to something like a total hip replacement. So a THR, the procedure is basically you would completely resect the femoral head, head and neck, ream down into the femur and replace the natural joint geometry with these metallic devices. We're going to go into a little bit of the history here, but basically we introduce these engineering materials into the joint space in order to restore function. So how do we test these devices to make sure that they're effective and safe before they actually go and are implanted into the human body? We use what are called hip simulators. So a simulator or hip simulation predates any in silico work, anything to do with computer modeling or anything like that, where that is usually referred to simulations. It's a large physical mechanical test scale rig. So these simulators, as early as the 1960s, take clinical components. A lot of the history and a lot of what I'm going to talk about today is the background is in hip replacements. So they take these clinical components and they articulate them through some kind of walking cycle in order to assess the geometry at the bearing surface, in order to test whether the wear rate is appropriate for going into the body. So the reason that we do that is polymer wear. So this is Sir John Charnley. So he was a surgeon based out of Wrighton Hospital, and he kind of invented and popularized the most successful modern total hip replacement. So this was the Charnley low friction arthroplasty. And everything around the design of this device and Charnley's whole philosophy around a metal on polymer bearing was that the friction transferred through the device had to be minimized. So he would recommend things like delaying surgery until you're older than 65 years of age, so that your activity level was lower. The polymer cups were small. Everything was around reducing that friction. He started off with PTFE, otherwise known as Teflon, again to drive that low friction. But those devices, the wear rate was catastrophic. The devices failed within a couple of years. So he eventually switched to high molecular weight polyethylene, and then the industry has taken on up to ultra high molecular weight polyethylene, meaning that the polymer chains are over 50,000 units long. But those devices started to perform relatively well, but the limiting factor quickly became the wear rate. And not to go into too much detail around this, but the polymer wear debris that was being released from the bearing, from the tribological interface of that ball and cup socket in a hip joint, was coming off in a fairly well-defined size range. and the bulk of that polymer release was being released in this submicron size range, which they termed the bioactive side range. So these hip joints release microplastics into the joint. Essentially, we've been doing this since the 60s, and your immune system, through a fairly complicated process, responds to them. Can't deal with them because it's polymer, it's an inert particle, but they treat it as an invading pathogen, really. Send out a lot of signals, and one of the consequences of that is you overproliferate osteoclasts, which are the cells responsible for destroying and resorbing bone. So you start to see aseptic loosening around the device, where the body is literally eating the bone away as a result of this aseptic infection, which the body is responding to. And ultimately the implant loosens, causes pain, and that's the kind of long limiting factor for the lifespan of these devices. So we use hip simulators essentially we take biomechanical profiles for what looks like a walking cycle. So this was the initial Paul curve from 1967, a biomechanical analysis where basically he had patients walking on force plates, and then he converted the force data from those force plates into joint contact reaction forces to get this typical twin peak loading profile. So where you have a peak in force at heel strike, a bit of a dip, a peak in force at toe off as you're walking through the cycle, and then the swing phases you take as your leg swings to take the next step. These biomechanical profiles have then, through various procedures and through to different ISO standards, which I'll talk about in a second, have been simplified to fairly simple sine wave collections into a simplified look at what this twin peak profile looks like. And then we apply these as part of ISO standard testing onto hip simulators in order to get a wear rate. So ISO 14242 is the standard for hip prostheses. There are standards for knee joints, spine joints, shoulders, ankles that cover basically all of the bases for the traditional joint replacements as they exist today. We run these tests out for 5 million cycles at 1 hertz, so they take anywhere from 3 to 5 months to run. We use fetal bovine serum as a lubricant because it has some of the same constituent proteins as synovial fluid, and we essentially run these devices, take the parts off, clean them, and then weigh them to get a gravimetric mass loss. And we use this gravimetric mass loss to assess the wear rate of new device designs, new materials, but essentially what we're doing is we're getting a benchmark wear rate. Those simplified profiles mean that the kinematics, the biomechanics that we're applying to these devices, the environment that we're subjecting them to, the fetal bovine serum is a mock lubricant. We dilute it with deionized water. Doesn't contain any of the lipids, the hyaluronic acid, any of the salt content that will be standard in synovial fluid, in order to basically have a consensus standard which is repeatable across different labs. So if a company wants to introduce a new material or a new device design, they essentially have to run a simulator test on the old device and then a comparable simulator test on the new device. And as long as the wear rate is lower or not any worse, really, then you can kind of compare that and draw conclusions to the clinical history. So testing these devices they're really just benchmarks. They're not representative of the conditions that these devices are going to be subjected to in vivo in the patient. It's a fairly simple analysis, which is based on this initial Paul curve, which surprise was a middle-aged white male, and we essentially don't test these devices in any representative scenario. And what that's led to, and I'll cover a few of these cases in a bit, is basically a very reactive nature in the industry. So devices are preclinically assessed, their wear rate is determined, they're then implanted, released into the body through clinical trials, and eventually, new product introduction to the market. And then we see a lot of failure modes that aren't captured in that testing, and then a lot of research goes into trying to understand why that failure happened, as opposed to doing it the other way, where you do the safety or the representative testing to make sure the device is safe beforehand before it's then implanted into people. So the bulk of my research has been around improving preclinical testing, and that's been through 2 main streams. The first one I'm going to talk about is representative inputs, so where we actually take patient-specific kinematics, real-world routines and adverse scenarios, and we run these on these simulators. These simulators are, particularly modern simulators, are quite nice platforms, fully electromechanically controlled. so that we can actually really closely replicate the gait profiles that we want to subject these devices to basically, rather than a simulated walking profile that's at 1 hertz over 3 or 4 months. That's not how we walk. We don't walk continuously forever. We go through different activities. We climb stairs, descend stairs, get in and out of chairs, jog, run, all the different profiles. Some of the most adverse and severe profiles that a hip joint in particular will be subjected to is just getting in and out of a car. That kind of deep flexion, deep leverage as you lever yourself out of a lowered car seat is fairly stressful for the device. So we spend a lot of time speccing out and designing and building hip simulators, tribometers in order to assess these devices how we want to. When you look at some of the old pneumatic or hydraulic comparisons to the demand curve for the load and the force that you're trying to apply, and then what you actually want to get out, the control methodology is it's not good enough to basically replicate what you need. So we have fully electromechanically controlled hip simulators where we can pulse up to 8 kilonewtons of axial force. We can go through fairly extensive ranges of motion and also apply cross shear forces, which is where a lot of the severity is the research is showing is coming from there. In terms of determining the profiles that we want to run these devices through, so as part of a study that we completed at University of Leeds, actually before we moved down to Birmingham, where we worked with surgeons and clinicians at Chapel Allerton Hospital to take a cohort of hip replacement patients. So these were people who actually had hip replacement devices put in. 2 years post surgery, we did follow up where we had these guys through into a motion capture lab in order to run them through various different profiles. And then what that enables you to do is to start, because this is a fairly large cohort of patients, larger than quite a few others that exist in the literature, you can start to stratify for different patient demographics and characteristics such as age, gender, BMI, and even activity metrics. One of the things that we found was that age wasn't necessarily a good indicator for activity. So Charlie delaying surgery until after 65 wasn't necessarily appropriate. And actually some of the better metrics are things like gait speed and a few other things. So we can stratify these patients into different demographics. We can, run this motion capture through musculoskeletal antibody modeling. So this was in collaboration with Antibody Tech, where we can take those motion capture trials and develop joint contact forces and profiles to put on the simulator that kind of, rather than, again, just that continuous walking, we can run devices through a day in the life of the patient or a week in the life of the patient. And we can do that for different patient classes. So the model took a little bit of refinement. One of the pre-existing studies that kind of exists out there is the orthoload data set, which was done by an academic in Germany called Bergman, where he actually took instrumented implants. So he had implants where he designed them with load cells built in, put them into patients. You wouldn't get that through ethics these days because those implants all kind of, I think they failed after about 2 years, but it led to quite a nice data set where you can compare the motion capture from our model and then refine it according to what the actual instrumented implants are telling you. So one of the things that we found was the muscle attachment points and various other parameters in the model were particularly sensitive, but we ended up getting a fairly close agreement on our model using the Bergman data set to what his implants actually measured. So one of the first tests that we did was just look at BMI. So we generated average waveforms for healthy weight, overweight, and obese patients, and you can see from the kind of just the profiles that they're very, very different from what we would run in terms of loads, in terms of the kinematics, in comparison to the ISO profile. When you look at that across the kind of wear track that the device will take across the bearing surface, again, the kinematics are very different. The principal forces and directions of sliding and sliding speeds at peak force are all very different according to this ISO profile. So hopefully this will run. Let me just, I may need to turn the laser pointer off. So this is just a video that's comparing the ISO walking profile. So it's 10 cycles of the ISO walking profile compared to just a normal physiological walking gait. And it really comes across in the sound. I don't know if the sound is going to transfer well, but the link to the video is here for you all to watch in your own time. So this is the ISO profile. fairly benign sine waves, and then it switches into that kinematic physiological gait. And hopefully you can hear the difference in those profiles running. You get an ear for these simulators when you're running them for a long time in terms of how they're supposed to sound. And yeah, just the kinematics, the severity of just a walking profile is very different from what we test these devices under. And the first thing we found is that even with those BMI profiles, even though the load was lower than the peak load in the ISO profile, so the ISO profile calls for a 3 kilonewton peak load. I think even the obese patient, the load was 2.7 kilonewtons peak. Our wear rates were much higher across the 5 million cycles. And again, you have to look at wear rate to basically convince everybody, because it's what people have been doing for a long time, but it's not the be all and end all. And it's actually a lot of what we're doing in terms of our research is moving away from just this wear rate as an assessment, but you still have to do it in order to convince everyone. But so for the obese and the healthy weight, there actually wasn't much difference, but over 5 million cycles, we were getting up to double the wear rate of what you would see on an ISO profile. When you look at the wear scar or the wear patch as a result of those articulations, you see very different not just severity of wear, but also very different kind of position in terms of that wear scar, much more superolateral for the cup, which matches with clinical evidence. So those were just BMI walking profiles for different patient demographics. One of the other things that we do is jogging profiles and adverse daily living profiles. So again, this is actually a jogging profile where the machine will pulse to 4 kilonewtons. It'll run 10 cycles of jog, and then it will stop and dwell for a period of time. So again, hopefully the sound translates. So it's a fairly nice capability that we have in order to not just run these profiles continuously, but in order to switch through kind of different modes of articulation in order to stop and stress these devices. And some of the things I'll talk about in a bit kind of suggest or hint as to why that's important. So again, we can run through these cycles as a day in the life of the patient. We've ran jogging profiles and stair negotiation, going both kind of stair ascent and stair descent, and found that basically compared to ISO, the wear rates are much higher. They're always much higher. Something that we noted that was maybe contra to accepted knowledge in the literature was that actually stair descent was much harder. There was a prevailing sentiment that stair ascent would be the more severe profile because you're in deep flexion, you're leveraging. But actually, one of the things that we've kind of noted across jogging and across stairs is some of the most severe wear patterns happen when you have really, really high torque. So getting back to that Charnley theory that getting low torques is important, and for stair down, the torque is much higher there. So something else that we're looking at, and I'll just skip over it fairly briefly in the interest of time, is using in silico modeling in order to try and assess the performance of these devices before you go to one of these lengthy tests, before you go to one of these 3-5 month simulator tests, in order to basically rub a piece of plastic again and not get a great deal of information. That should be a fairly simple thing to model using fairly simple FEM techniques. So that's something that we're expanding in order to try and generate the regulatory evidence that you need in silico to inform the kind of testing that you maybe still need to do before you then start to kind of assess the safety of these products. So the second arm of what I've been doing is really looking at those appropriate outcome measures. So polymer wear, this bulk kind of benchmark wear rate, it's not appropriate across all devices and doesn't really tell you much. It doesn't give you a lot of information as to how this device is actually going to perform in vivo. And one of the examples of failure of that is the metal on metal clinical debacle, crisis, travesty that happened a few decades ago at this point now. So when Charnley was doing his metal on polymer hip replacement, there were another group of surgeons who were trying metal on metal devices, and there is some background lubrication theory that would suggest a metal on metal device that's functioning something like a journal bearing, where it's in training lubricant, that lubricant pressurizes, and you enter EHL, elastic hydrodynamic lubrication. You can separate the surfaces, and then if your surfaces aren't in contact, you're not wearing the device. those initial bearings, the McKee-Ferrar or the ring metal-on-metal prosthesis, they all failed catastrophically, so they weren't really taken very far. And part of that was around the manufacturing processes, but around the early 2000s, well, it would have been late 90s, there were patients who were starting to turn up, going to their doctors who had a McKee-Ferrar or a ring metal-on-metal prosthesis, and they'd had it in for 20, 30 years, and it worked fine. So those patients, the reasoning around why they'd been so successful is they just managed to get lucky with their bearing match, and actually they'd gotten a lot of their bearing had operated fairly favorably tribologically. So they, with modern manufacturing technology, they tried to introduce another generation of metal-on-metal devices. And again, they kind of focused on this wear rate. So compared to a polymer device, the wear rate from a metal-on-metal was, orders of magnitude lower. But after around 2008, they were only really predominantly put in the early 2000s. These things started falling out left, right, and center. So there was all kinds of new failure modes that hadn't been seen before, adverse reaction to the metallic debris that was being released, pseudo tumors, these kind of either soft or hard growths that were appearing in and around the joint replacements, sensitivity to metal to pain, or metal sensitivity to the metal, pain, general just really poorly performing devices, again, because they focused on this wear rate as a measure of success. The reactive nature of that was, in the literature, was to look at basically adverse loading profiles to try and explain why they'd failed so badly. So some devices were observed to microseparate. So during the cycle, during the swing phase of the cycle, if you had any kind of joint laxity or malalignment of the device, the bearing itself would separate, and then when you came back down on heel strike, they would collide, and that collision would form a much more severe contact. All these devices, because of their lubrication mode, were fairly sensitive to the positioning and the placement of the device. Really surgical factors, how the surgeon put it in. So if you had a nice acetabular inclination of around 30 to 40 degrees, you had a fairly captive joint space for entrainment, for lubricant pressurization. Anything higher, exceeding 50 degrees, you were starting to compromise that. And again, this was all explained in terms of wear rate. When you had microseparation, the wear rate slightly increases. Where you have acetabular inclination, the wear rate slightly increases. So one of the things that my PhD focused on was actually looking at in situ sensing of the metallic degradation. And you can do that fairly simply with electrochemical techniques. So you implement what's called a three electrode cell into your metal-on-metal device. This is what a lot of my PhD focused on. So you measure the corrosion directly at the bearing surface using fairly simple, fairly well understood corrosion theory, electrochemical theory that's existed for a while. When you speak to electrochemists about how you're applying these techniques, they often cringe because they do their measurements in really well controlled environments, and we just put a probe into the hip simulator that's full of gunk, which they kind of don't appreciate. But you can get fairly nice data that directly links the tribology of metal-on-metal bearings, what's happening at the surface, to that electrochemical degradation. And one of the things I focused on was measuring these prevailing adverse loading profiles, and found that in the literature, whereas if you introduce microseparation for a certain bearing, you might see a twofold increase in wear. If you measure the corrosion that's occurring directly from the bearing surface, you see an order of magnitude increase. So you see that not only is you're releasing more metallic debris into the joint, but you're actually also releasing corroded metallic ions. So these things coming off as a result of the corrosion and chemical processes that take place. So that mechanism of degradation has shifted as well. One of the things that you can use, and one of the reasons we're moving to in situ sensing as well, you can use electrochemistry to do is characterize in a much shorter time frame the severity of profiles. So this was some work that I did looking at increasing that inclination of the device, and you can see that if we increase from 30 degrees up to 50 degrees, you get this nice trend or increasing in the corrosion current coming from the bearing, and you can get that over. I think each of these profiles was 600 cycles. As opposed to months and months when you're running these tests. And one of the things that this kind of showed when you increase in parallel or when you increase in series is once you go up that inclination, i.e. you're compromised the lubrication, you're exposing a different area of the metallic bearing to tribological action. When you come back down, you still see increases in degradation. So again, that kind of speaks to the fact that running these profiles at 1 hertz continuously for months under the same articulation profile, under the same contact area within the bearing, is not fully capturing what these devices are going to undergo in vivo, because you're going to be, subjecting them to very different profiles, very different areas of the articulation interface, and this all has a compounding effect when you return to a standard profile. So one of the other things that I've looked at is modular tapers. So a typical traditional hip replacement these days is not just a simple ball and cut bearing, but you also have different interfaces which are subjected to fretting corrosion. And the justification for these tapers is they're described as self-centering, they're described as locked once you put them on, but actually there's a fairly significant source of corrosive and degradation there from metallic ions as well. And one of the things that we did was look at how these things move. So again, they're described as self-centering. Basically, a surgeon comes along after implanting the stem, he'll sit the head, or he or she will sit the head onto the stem trunnion, and they'll just whack it. And there's a massive range in difference in terms of how a surgeon will align that head, how much force they'll apply when they strike it, how many times they'll strike it. And what we found is when you strap these things with sensors and you try and measure the motion of these devices, and you again hook them up with electrochemistry to quantify that degradation. We looked at various different engagement philosophies and surface roughnesses, but they all behave differently. The industry kind of has this view that modular tapers just work and they're fine, and actually they kind of take care of themselves. But these things, when you measure them and you apply complex motions to them, these things the engagement area migrates and moves up and down the taper in all kinds of weird, wonderful, unexpected ways, which is changing the contact conditions of that interface and changing subsequently the degradation that's occurring. One of the things that we found is predominantly one of the predominantly used taper philosophies is a proximal engagement with a rough surface. So a lot of these devices basically only engage at the end of the taper surface, and they have these this kind of rough as machine surface or threaded finish. And actually, those proximal devices are some of the worst performing in terms of tribal corrosion and in terms of axial motion that we measured. So I'll skip through that. It's just a lot of data. But one of the things that we're also instituting at Birmingham is the Birmingham Implant Retrieval Centre. So when we test devices on the simulator, we run them through months of cycles and then we take them off. The parts are worn, sure, but they essentially come out looking pristine. They've got wear scars, but they come out looking close to new devices. So one of the initiatives that we kicked off with the Royal Orthopaedic Hospital, which is just down the road from mechanical engineering from the University of Birmingham, is a collection clinical trial that we've actually set it up as, where surgeons, anytime they take out any piece of metal work, any joint replacement, it can essentially go in a box and it comes to us for analysis. And one of the kind of key things that we're seeing right off the bat is devices that come out after 15 years, say, where you would consider that as a success. It's lasted for 15 years. It's restored function to the patient for a long period of time. It's a well-performing device, but it's failed for whatever reason. They come out looking mangled. They come out destroyed, articulating on all kinds of different areas, and it just kind of again reinforces that message that how we test these things preclinically in no way represents the scenarios that they undergo in vivo. So we need to do better in terms of that preclinical assessment. So that's it from me, and thank you all for your attention. If there's any questions, feel free to reach out at my email address, or I could address some quickly now if anybody wants to stick their hand up.
Thank you very much.